over to you and we can just jump right in. Thank you.
Thank you very much. Happy New Year, everybody, and welcome. Thanks for joining us. I thought we're at a very dire time in the United States, actually in the whole world, with the coronavirus, but the vaccines, there are two that are here. I have never seen such rapid publication of phase 3 trial results in a peer-reviewed journal as has occurred. Pfizer, or what's called the BNT vaccine, was published early in December, and the Moderna vaccine, the other mRNA vaccine, was published December 30th. What I thought I would do is really review phase 3 data, both from Moderna and from the Pfizer vaccine. I want to say that I actually, for the Moderna vaccine, have taken many of the slides that were presented to the CDC Immunization Practices, ACIP group. The Pfizer vaccine, I took many of the slides from the FDA presentation, though there was a nice Kaplan-Meier in the New England Journal that I took for that. I'm also going to talk, just yesterday, the MMWR published a review of the anaphylaxis cases with the Pfizer vaccine. And so I'm going to present that. And also just yesterday, the CDC updated their guidance as far as recommendations for COVID-19 vaccination. And I want to apologize right off the bat. I've got to something else that I have to be at 1. I so apologize. Believe me, I'd much rather be here. But I am so grateful to Lisa Costello, who is on and who can really, I think, speak knowledgeable about, well, about everything, but particularly about the state plans. And also I communicated with Dr. Marsh. He is got something until 12:45, but he will try to join. If it goes long, he won't be able to.
Dr. Carter, I do apologize. There's a little bit of a static noise during when you speak. So I think sometimes if the phone is near the computer, it might interrupt the connection a little bit, but we can hear you. It's just a little bit of static.
Okay, maybe if I move closer to my computer, is that any better?
That's okay. Much better, yes.
Right. The other thing I'd like to do is I'm having trouble. Oh, there we go. I'd much rather see your pictures than the slides, but it was blocking out the slides, but I figured it out. Okay, so we're going to talk first about the mRNA vaccine from Moderna. This vaccine was actually developed at the NIH Vaccine Research Center, and in partnership with Moderna, they have conducted the studies. This is, you know, a messenger RNA that encodes the spike protein. It goes into the endoplasmic reticulum and Golgi, and then the spike protein is produced. I think it's really important to remember that mRNA never gets in the nucleus of the cell, and it is then does not hang around. So that's really important, and that is also true of the Pfizer vaccine. The phase 3 study design, it was a double-blind, randomized prospective trial of roughly 30,000 folks, randomized 1-to-1 to either get the vaccine, the dose was 100 micrograms, 2 doses, 4 weeks apart, or saline placebo. The case definition, the way they defined the primary endpoint, were symptoms. You either had to have 2 or greater than or equal to 2 systemic symptoms shown there, or you could have a respiratory symptom, but in either case, you had to have a confirmatory SARS-CoV-2 PCR. And I think it's interesting. I think, you know, at the time these trials were being designed, everyone believed that this was predominantly a respiratory virus, but as we've subsequently come to see, that there is really sort of systemic effects. The primary analysis was adjudicated greater than or equal to 2 weeks after dose 2. So the primary analysis looked at infections that started occurring 2 weeks after the second dose. This just really looks at the participants, and you can see in this trial, age range was 18 and above, 18 to less than 65 without comorbid conditions were 60%. So almost 2/3 were younger folks with no comorbid conditions. 17% were that age group with comorbid conditions. Comorbid conditions are shown at the bottom of the slide. And then this trial had about 25% of folks who were greater than or equal to age 65 with or without comorbid conditions. The racial and ethnic breakdown is shown on this slide. And if we get to the primary efficacy objective, you can see again the definitions we gave starting 2 weeks or more after the second dose. There were 11 cases in the vaccine group. There were 185 in the placebo group. If you put 11 over 196, which is the total denominator, you get that there were about 6% of the cases in the vaccine group and the remainder in the placebo group, which is how they calculate the vaccine efficacy with the 95% confidence interval shown there. Obviously, this is highly statistically significant, and the incidence rate per arm is shown in the last row of this table. This just looks at the point estimates with the confidence intervals for a number of subgroups. And the only thing I'd like to really call your attention to is that, in no group is the point estimate less than 80%. In many of the subgroups, it is much greater than that. And this is really, as has been talked about, amazing efficacy. I mean, with the exceptions of the measles vaccine, which is at about 95%, we really, this is a rare event to see efficacy this good and is quite reassuring. I think that, an important endpoint was also what about the ability of the vaccine to prevent severe cases, ICU admissions and intubation. And you can see here in the vaccine group, there were 0 severe COVID-19 cases versus 30. And you can see the incidence rate shown there. And I think that again also is, highly reassuring. This is a Kaplan-Meier that just shows the cumulative rate of occurrence of COVID-19. These are all infections, not just severe infections. And you can see that those curves start to, splay out at about 3 weeks. The first and second doses are shown there. They also, in this trial, did nasopharyngeal swabs prior to the second dose. And this was interesting that in the group that there were no documented COVID-19 symptoms between the first and second dose, 14 individuals in the vaccine and 38 in the placebo actually had positive PCR. These are pretty small numbers. They're suggesting that there's efficacy for prevention of asymptomatic infection. I think that probably those numbers, we cannot firmly, with confidence say that is true. And I think one needs to remember that these trials, these phase 3 trials, were not designed to look at whether or not the vaccine prevents transmission. And you really need to keep that in mind. There's no doubt about it that they prevented symptomatic disease. But the data about whether asymptomatic infection that would be capable of transmission is possible, you can see that they're very small numbers. Just looking at safety, not shown on this slide are the local reactions, which were about 80% and went up even higher with the second dose. Shown here are the adverse events related to the second injection. I chose that slide because the first injection were less. Fatigue, as I remember, was 30–40% with the first one, goes up to almost 70%. And if you look at this, interestingly, the side effects are somewhat more common among younger individuals, shown on the left of each of the columns here versus the right. And that may be just related to the amount of vigor of the immune response. I think it's important to note that there were no grade 4 adverse events, and by and large, all of these were really either grade 1 or grade 2. It's interesting, this slide, the grade 2 color is off. It looks in the key, it's light green, and in the diagram, it's blue, and I apologize for that. Now, with the Moderna vaccine, they looked and advised that no participants were excluded for history of anaphylaxis or other significant hypersensitivity. There were 2 anaphylactic reactions reported. However, one was in the placebo group and occurred 10 days after the first dose. The second was in the vaccine group, occurring 63 days after the second dose. And the conclusion there is that those anaphylactic reactions were not related to either the vaccine or the placebo. And when they looked with a standardized query, there were no events that really met definition. This is just a summary. I'm not going to review it other than to say that, the efficacy was extremely high at 94%, that the safety, there were frequent adverse events, but they were mild and resolved quickly. And, I think that obviously the FDA granted emergency authorization to this vaccine. Now, moving to the Pfizer vaccine, the Pfizer vaccine was developed in collaboration with another company called BioNTech, and this vaccine is referred to as the BNT162, if you see that. This vaccine is also an mRNA vaccine formulated in a lipid nanoparticle that enters the cell. The spike protein is made and processed, and spike protein actually fragments are produced by the cell, which then are presented to helper T cells, which stimulate B cells to produce antibody. An interesting difference is that the Pfizer vaccine actually activates CD8 cytotoxic cells. The Moderna vaccine has not been observed to do that. Whether that is ultimately going to be important, I think the jury's out, but it is a difference between the two. These are the demographic characteristics in the phase 3 study. This study had over 43,000 participants. The age range here was 16 or greater, whereas the age range with the Moderna had been 18. And you can see at the bottom that almost 21% of individuals were 65 or older. The case definition for the primary endpoint here was similar, but there were some differences. A case was counted. Here you only needed one or more of the symptoms shown there. And as with the Moderna trial, you had to have confirmation of a positive SARS-CoV-2 PCR. Now, the Moderna vaccine, the primary endpoint was counting cases 14 days after the second dose. Here, it was COVID-19 occurrence 7 days after the second dose. Another difference, as I'm sure you're aware of, is the Moderna vaccine is given 4 weeks apart. The Pfizer vaccine is given 3 weeks apart. And these were subjects who were without evidence of infection prior to 7 days after the dose 2. So that's what they were looking at. And you can see in the vaccine arm, there were 8 cases, and in the placebo arm, there were 162, and the efficacy is 95%, very similar to Moderna and absolutely superb. If we look at the subgroup analysis, again, this is a different format, but similar to the subject matter that I showed with the Moderna vaccine. Again, you know, you see that subgroups, if you look by subgroup, all subgroups had an absolutely superb efficacy rate. Again, looking at severe disease in this trial was the CDC definition, which was hospitalization, ICU admission, intubation, or mechanical ventilation, or death. You see that greater than or equal to 7 days after the second dose, there were 0 cases in the vaccine versus 5 in the placebo. If you look earlier, after the first dose, you see that there was 1 case in the vaccine and 14 in the placebo. This is taken from the New England Journal paper. And, you know, this one shows the Kaplan-Meier. So this was incidence, and this was infection, not severe disease. So all of the infection, and it looks out for the duration. And the little, you know, blow up there in the left-hand corner of the Kaplan-Meier is really sort of magnifying what happens between the first and second dose. And you can see that the lines start to diverge at about 11 or 12 days. And again, people have said, well, this is suggestive that the vaccine is protective after the first dose. I have been appalled, absolutely appalled, that individuals in the United States in leadership positions in some institutions have suggested that perhaps we should just go with 1 dose. I think that is unconscionable. I think it's unethical. We have no idea what would happen to that antibody response after the second dose, or what would happen to the infection rate if you didn't give the second dose. So this may be, you know, a bit reassuring. Maybe there's some protection, but I don't think that anyone should even consider not giving the second dose. Similar to what I showed with the Moderna, these are, again, after the second dose, the systemic side effects. As with the Moderna vaccine, the Pfizer vaccine had a very high rate, 80 to 90% of local reactions that resolved over a couple of days. The systemic side effects are shown here. And again, it's interesting, you can see that they're a bit higher in the younger age group versus the older age group. Now, I want to switch gears a bit. This is the MMWR that was published yesterday that reviewed reports, 175 case reports of possible allergic reactions to the Pfizer vaccine, only the Pfizer vaccine. Of those 175 reports that were received, 21 were adjudicated to be cases of anaphylaxis. The rate is shown there. Interestingly, 90% of those were in women, but you got to remember that 64% of vaccinees were women, so it was not just 1-to-1. There have been other sort of vaccine adverse events that have been a bit more common in women, but I think the numbers are so small here that one cannot make firm conclusions. The median interval from vaccine to the anaphylaxis was 13 minutes, and I'll just go to the next slide, which shows those 21 cases and shows time after the vaccine in which the symptoms of anaphylaxis occurred. You can see that only 3 individuals were greater than 30 minutes. There was 1 individual right out at 30 minutes. Going back, 20 of the 21 have actually been followed up. There is 1 case that's really, 20 of the 21 cases have completely recovered. There's 1 case where they do not have the follow-up. That doesn't mean that individual didn't recover, but they just didn't have the data at the time of publication. Of the 175 case reports, 86 were non-anaphylaxis, and 61 were adjudicated to be non-allergic adverse events. There are 7 cases that are still under investigation. Based on that, the recommendations in yesterday's MMWR were really to, at the time of vaccination, ensure ready availability of necessary supplies to manage anaphylaxis. Again, we're talking, a very uncommon occurrence, but epinephrine should be there in pre-filled syringes if you need it. Screen for contraindications and precautions to getting the vaccine. They suggest post-vaccination observation, 15 or 30 minutes. And, immediately, if there's any suspicion of anaphylaxis, one should immediately treat with IM epinephrine. And the vaccine recipient should be counseled to seek care if any signs or symptoms suggestive of an allergic reaction occur. I should have said in those cases that were deemed not to be anaphylaxis, but to be, related possibly to an allergic reaction. Most of those were skin manifestations or itching or things like that. Yesterday, the CDC also updated their recommendations for considerations for use. And again, these were of both of the mRNA vaccines. And their contraindications were really severe allergic reactions, that is anaphylaxis after a previous dose of one of the mRNA COVID-19 vaccines or any of its components. And you can see their caveats that I have asterisks at the bottom of the slide. Immediate allergic reaction of any severity to a previous dose of vaccine or any of its components. And the suspicion is that polyethylene glycol may be an agent of this rare anaphylaxis. That's not confirmed. And then also immediate allergic reaction of any severity to polysorbate due to the potential cross-reactivity of hypersensitivity. I think, though, that if you read, and it's really quite good, the considerations for use of mRNA vaccines, they quite clearly say that, when they're talking about contraindication, it's really a previous dose of these mRNA vaccines, or really the PEG, the polyethylene glycol, or polysorbate. And they really sort of say that though one should take precautions for individuals who have experienced anaphylaxis to other agents, that should not be a contraindication. And I would urge everybody to read these clinical considerations that came out yesterday. They were really terrific. And with that, I think that is my last slide.
Thank you so much, Dr. Hutter. I was able to stop the share, so thank you so much. That was wonderful and super timely and informative. We did have a few questions coming through the chat, but before we jump right into those, Dr. Costello, was there anything you would like to add as well before we go into the Q&A portion?
No, hopefully you can hear me. I'm here on the floor of our joint interagency task force, and sometimes the internet goes in and out. But just thanks to Dr. Hodder. I think that was excellent, and appreciate all of her ongoing work in this Project ECHO. Certainly, seeing more and more vaccine in our state. We continue to lead the nation in our vaccine administration rates. We certainly think we can do better, and we want to continue to work on improving that. But I think it's important for us that we continue to educate. I can just say anecdotally, many of my colleagues and friends who have gotten that second dose certainly report feeling more of a response. And so I think as we continue to progress further and move to more general population in our education efforts, it's going to be important to understand what the data shows and then to be able to communicate that in a clear, consistent, and scientifically sound way. So thank you, Dr. Hodder, as usual, and I look forward to answering any questions that I can.
Yeah, you know, one thing that I had meant to put in, and of course then I got distracted. There's a vaccine adverse events reporting system, VAERS, and what we will do is I will just find that link and make sure that in the wrap up that Mitra can include it for everybody. I think it's really important, particularly with new vaccines, that, you know, potential adverse events are reported. So I just did want to make folks aware that that reporting system is available, and we will, you know, make available to you the link.
Absolutely, thank you, Dr. Hutter, and certainly we'll include any resources and links in the recap email. All right, so we'll just jump right into some of the questions coming through. The first one we got in was asking, do you think the Moderna and Pfizer vaccines will provide protection against the new variants, B117 and 501V2?
Well, that's the $64,000 question. The working assumption is yes, but the studies are ongoing, and I have not seen the data out. What they're doing is they're actually looking whether or not the neutralizing antibodies from individuals who got the vaccine will neutralize these new variants of the vaccine. I would say hearsay among the infectious disease vaccine community is they feel that almost surely it will protect against the UK variant. The South African variant that has been described has multiple other substitutions, mutations, and along the spike protein. And so, you know, the working hypothesis is the vaccine will work, but I think that we'll have to see.
Thank you so much. The next question we've gotten was asking, do you think that the newly EUA-approved monoclonal antibodies can have therapeutic efficacy against the new SARS-CoV-2 variants?
Well, again, that is unclear. There is some concern that they will not, but I don't think that we know. I would say, and this is not answering the question, but I would say the other question that I have been asked is, what about people who get the monoclonal antibody, you know, should they get the vaccine? And we know from other vaccines, for example, if you get immunoglobulin and then hepatitis A vaccine, you know, that antibody in the immunoglobulin, which hangs around about 90 days, up to 90 days, can actually, you know, really preclude a good antibody response to the vaccine. So the suggestion is that there be a delay of several months, and there have been very few recurrences, reinfections of SARS-CoV-2 within 90 days of the first infection, so that's considered safe. Whether the monoclonal antibodies as therapeutic agents will work against the new, you know, sort of variants, I think we'll have to see. I don't know, you know, Lisa, you know, please chime in.
Yeah, no, I think that the question is a good one and one that we got frequently. I don't know if Dr. Marsh is going to hop on, but he has his belief of this. He feels that, you know, we shouldn't be delaying vaccination, even if monoclonal antibodies are given, just especially in high-risk populations like those in our long-term care centers. West Virginia, we were the first in the nation to offer vaccine to all of our long-term care. There are some states that they don't have their first appointments in long-term care centers until February. So we will, you know, complete our 2-dose series in most of our facilities before some states even start. And we've had a very targeted approach to try to get more monoclonal antibodies into long-term care facilities, given the high risk of that population. And so I think it wasn't studied. And I think I really appreciated Dr. Hotter's point about the unethical and unconscionable thought to not give the second dose. I think that, you know, as scientists, we should be sharing the information that we know, and also informing the public of what we don't know, but what we think based upon our understanding at this time. So I think we'll continue to get that question of, is it is it safe? I think it's just unclear the type of immune response one would get. There was a question about, if you've had COVID, should we be checking antibodies? That was not recommended. I think it's one thing from an educational perspective to identify, and understand, the antibody response before vaccination, and then checking to see, is there, a better response, and Dr. Hodder may be able to speak if those type of studies are going on. I would assume or hope they are, but I think that, the same goes with the monoclonal antibodies of not knowing what type of immune will achieve when they receive the vaccine, if they've also received those. So as we've said throughout this pandemic, we still don't know everything. We're learning more, but we still have a lot left to learn.
Yeah, I would say, and I think this was actually addressed in the recommendations that came out yesterday. But the problem with the monoclonal antibodies is, so you give the mRNA vaccine, your cells are sort of, really spewing out S proteins to stimulate your helper cells and B cells to make antibody. But if you've got monoclonals sitting there that can, sort of bind when that, protein comes out, it's not going to be able to be presented to the immune cells. And that is, sort of the theoretic explanation. Other sort of immunoglobulin for other viruses, it's been shown to really diminish the immune response. We have not specifically studied it here, but I think, as I read those recommendations, they do address that. I see somebody in the chat. It's absolutely right that antibody assay after the vaccine is not recommended. And after you've had the illness, actually antibody, it's not clear what it means. There are all sorts of antibodies that you produce. The ones that are believed to be most protective are neutralizing antibodies that neutralize that virus. So, I think that in the setting of clinical studies, it's an important thing to look at, but I don't think routine clinically that makes a lot of sense. There have been papers that have shown people who have gotten COVID-19, if they've had very mild symptoms, that often their antibody levels are lower than people who've had very, very severe disease. And yet over time, after the illness, antibody levels wane. That's not surprising. The question is, if you're re-exposed to that, sort of virus, do you have a quick amnestic response? And I think those are some of the questions that are not known.
Thank you so much, Dr. Hodder. And I know you have to hop off here shortly. So I wanted to ask one more question that came through for you, asking that the NHS in the UK has approved the second dose to be interchanged with either the same vaccine or an alternate one. So for example, the Moderna for Pfizer and vice versa. So they're just wondering what evidence is out there that shows that such a vaccination regimen actually works.
In my opinion, these vaccines should absolutely not be interchanged. That's not how we did the studies, and that's not what the science says. And I think that is a dangerous recommendation to make. If you're going to have science, then you take the data to maximally know what the protection is going to look like. The other thing that has, the question that was raised is, what about that window, sort of 3 weeks for Pfizer or 4 weeks for Moderna? Actually the recent CDC guidance from yesterday said probably, you can maybe just go 4 days earlier, but no earlier than that. And it's better to really give it at the time. There is no contraindication. What if somebody can't make the Pfizer sort of second dose in 3 weeks or the Moderna in 4, they show up at 6. The advice is you give that second dose and you don't need to restart the series.
Yeah, and I think that's a really important part to emphasize, because we have received many concerns of, we didn't get our dose on the same day, it's not 21 days, am I not going to mount an immune response? And I think that's where we have to have education, that it's what Dr. Hodder was saying, it's really that minimal interval. So we really have been, really recommending you should be waiting at least until that 21 days to then get that second dose. And ACIP's recommendation were clear. I think in the studies, the longest they went was 42 days, but they don't think that you need to like restart that series, and hopefully it wouldn't be that prolonged period. But we've had cases where, individuals get COVID between they get their first dose and then they get COVID and they have to wait until they've completed their isolation. So there's many different factors that go into play, but we've been getting a lot of questions about that. And so I would speculate that many of those on this echo may be getting calls from patients asking that as well. So we've definitely been trying to do some education on that piece, that we want it to be as close to that day as possible. But if it's not the exact day, we still have belief that you're going to mount an immune response. We want to get it as soon as possible, but we need to be reassuring that you don't have to then restart the series or those type of things to just provide some reassurance to our patients and the public.
Thank you so much. And I wanted to direct everyone's attention to the chat as well. Lots of great questions coming through. And thank you, Dr. Costello, for answering some of those as well, and including the links. We got a couple questions asking about how, if there are opportunities for healthcare workers to volunteer to administer the vaccines and help increase the rates of vaccination, and just overall questions about volunteering. And I saw, Dr. Costello, you had answered that, but I didn't know if you wanted to maybe elaborate it for the group as well.
Sure. So we're working on a couple opportunities for the state to expand volunteer opportunities. There is a system called West Virginia Ready that was put into place after the floods in Greenbrier County. So you can go in and register there even if you're retired, and then you can identify which counties you would want to help in, and at the local health level, they can reach out to you there. Additionally, we're working on a project that's called the West Virginia VAX Team, Vaccine Administration Collaboration Support Team. We will work to utilize and ensure proper training of health professional students throughout the state that then will support vaccination events in a variety of areas. And those teams will need supervision, of course. So those who are already practicing physicians engage in that capacity as well. There is a limited supply of vaccine that is coming to the states. I said West Virginia, we are leading the nation in regards to our per capita. Yesterday, there was a call with the White House. We had vaccinated 3.4 West Virginians per 100,000. The closest state to us was 2.4 per 100,000. So, we are trying our best to get vaccine out and get vaccine arms. And we are using multiple partners. I know that it's encouraging to me that there is such a demand. I think that we want to try our best to sustain that demand and ensure that we're providing clear, consistent, and scientifically sound information so that individuals can make the best decisions for themselves and their families. And a lot of that with education, that these vaccines are safe, effective, they've gone through the process, that can be trusted, as Dr. Hodder spoke to in this trial data that we're seeing. So as this vaccine to roll out and we see a larger supply come, I look forward to the day that we can offer access to everyone. There will certainly be an ongoing need for volunteers and to increase the amount of vaccinators we have. So I put into the chat the West Virginia Ready system, and then we will be sending additional correspondence out about engagement of the health professional students here in, as that program gets further off the ground.
That's really great. Thank you so much. Another question came in saying that the World Health Organization, SAGE, has made a recommendation for Pfizer vaccine between the first to second dose up to 6 weeks. So they were asking, what are your thoughts for the 3 weeks to be extended to 6 weeks?
Look, it's the same darn thing. We had a trial of 44,000 people. It was 94% effective when they gave it at 3 weeks. Now, why you should extrapolate and say 6 weeks, maybe it's as good, it's a boosting dose, but for heaven's sakes, go with the data. If somebody can't get there at 3 weeks, as we've said before, they just get the second dose then later. But the target should be the way the study was conducted. And I just, this is a crazy world. And I cannot understand, we have great vaccines and we have absolutely terrific clinical trials that were conducted. We need to use those data, not try to sort of say, well, we'll only give one dose. We'll give it at 6 weeks instead of 3. I mean, this is nonsense, nonsense. We have data and you have to really sort of go with the science. And I have absolutely no respect for folks that are giving these recommendations that aren't based on science. That said, we all understand things happen. People can't get there at 3 weeks. Then you give them the second dose when they get there. But that should not be the guidance. I don't know, Lisa, what do you think?
I don't think I can say it any better than that. I mean, I think that, throughout this pandemic, there's been a lot of times that we had to go off of what we thought was best. And we've learned, if we go back to a year ago, we were recommending hydroxychloroquine. That has been proven time and time again to not be what we initially thought it would be. And so, I agree that I think we need to be basing our recommendations off of what we know. We need to continue to study and learn, and that will happen. But I completely agree. And in the Britain study, I mean, Britain has not approved or authorized Moderna. They authorized AstraZeneca, which to me is even worse because it's not even the same type of vaccine. I could see arguably in the future, once we study more, perhaps the mRNA vaccines will be interchangeable. And ACIP has said if there's in the rare event that you did get one Pfizer and one Moderna, that you don't have to repeat the series, but we don't know because we've not done the study. So I agree completely with what Dr. Hodder said. And I am very worried about what the UK's recommendations are because to me, I just don't understand giving an mRNA and then a viral vector-based vaccine and being able to say that you feel with confidence that you would mount an immune response that was seen in these studies. So I agree with Dr. Hodder. I think that we need to do the studies to answer these questions that we have, but for now we need to be, basing our recommendations off of the data we have based upon the work that's been done thus far.
Thank you both so much. And I just wanted to share what's coming through in the chat. We got a couple of chats saying amen, and Dr. Rexroad saying she agrees with Dr. Hodder and second to.
I do think there was a question about if you got the wrong dose the first time. It seems like if there was one, I mean, I think that obviously if that error occurs, it needs to be marked in VAERS. Someone provided the VAERS, the Vaccine Administration Adverse Event Reporting System. So definitely that's an administration error. So you want to make sure that that's reported so that it could be studied. And then I would likely recommend, getting the second series. Again, that whole, I don't know what you do with the antibody result when you get it, and I think that, in my opinion, I would complete the series to do that and not based upon, it's really, I think, just how our immune system works. You're trying to get that boost dose to provide that subsequent antibody response. So that would be my recommendation, and make sure that it is reported because we need to be monitoring these administration errors and any adverse events that Dr. Hodder spoke to in her didactic.
Thank you both so much. And that was actually the last question that I was going to ask to have addressed fully in depth. So, and you just did that. So thank you so much. We don't have any other questions coming in through the chat as of now, and we have about 15 minutes left. So Dr. Hodder, Dr. Casella, any other comments you wanted to share with the group?
Well, I just want to say thank you all. And thanks to Lisa. Clay texted me and said, surprise, his call went over. But, and I'm going to have to jump off, but maybe Lisa wants to review the, sort of plan for the state and how they're going to, what's planned for the rollout. And again, thank you all. Stay safe. I'm going to jump off. It's always fun to be here. Take care.
Thanks, Dr. Hodder.
Okay. We'll see you next time.
I did want to just take a moment and with Dr. Hodder's recommendation, the state is receiving many calls and questions about, when, where, how, when will I get my vaccine? Where can I get it? How do I sign up? And certainly as I mentioned before, the state is committed to providing access, to West Virginians as soon as possible. This is really dependent upon our federal allocation, and there are many different moving parts to it, and certainly trying to work as a team here in the Joint Interagency Task Force to get vaccine out and then get it administered. And so, also urging some patience as well. And as I mentioned in my prior comments, really, I hope that we can sustain the demand that we're seeing of interest in individuals wanting to get the vaccine. And we'll continue to do those education pieces. But in regards to where we're currently at with the vaccine plan, there are phases that have been identified based upon recommendations from CDC and ACIP, as well as our own state's epidemiologic data. And Dr. Marsh has spoken to this in the governor's press conferences, that really when you look at the state of West Virginia, and the governor has referred to this as well, age, we see the older individuals have more mortality and morbidity that is significantly impacting in our state. Additionally, we saw very significant morbidity and mortality in our nursing home population. So West Virginia, we took a different approach than other states in that we did not activate our federal pharmacy partnership, and rather did a state-based model. And so we did, within the first 2 weeks, offer vaccines to all long-term care and assisted living facilities in our state. Many of those are starting their second doses this week of those who received the Pfizer product, and then we'll continue with the Moderna product. And then there's subsequent, we know that there's a lot of movement in nursing homes, new residents, new staff, and so there will be ongoing administration of first doses as well. And then really, I think there's been a lot of confusion about phases, and really the phases overlap. It's not sequential, like you don't have to complete one phase to move to the next phase. And so we have been focusing on healthcare personnel, as well as first responders, individuals that focus on maintaining critical infrastructure, so local health departments. And then also, as starting today, actually vaccinating educators. And then last Wednesday, many saw that the governor did open up to the over 80 population. And again, this supply is limited, and there are ongoing movement within the phases to offer vaccine. The process for that, I know that there's been a lot of questions for the healthcare professional community. The way that process works is that many of you may have been contacted by your employer. So I didn't mention, but the acute care system, so the hospital-based systems, those who were on the front lines caring for individuals in ICU COVID units, those individuals were focused on, certainly as a priority in the beginning, and working on hospitals. So many individuals may have been contacted by their employer, community-based or community health centers. I know there's individuals on from the primary care associations. We've been working very closely with them in regards to getting access and vaccines to community health centers, who are also immunizing their patient population that are over 80, and will continue to play a critical role in our school-based health centers, playing a role in vaccinating educators. And so the process for that is you get an email from your licensing board. Please check your spam, check your junk, because most people are like, I didn't get a survey, and we're like, did you check your spam? And then they go back. And so those individuals complete that survey. That information gets communicated back to the state. The state, based upon allocation, uploads that information into what West Virginia is using for our phase 1 participants, which is the vaccine administration management system. And then once the names are uploaded into that system, you will receive an email from the VAM system, also with information as to where to schedule that vaccine. So for instance, many healthcare professionals were instructed to schedule at a pharmacy. Moving forward, the goal and the plan is to open up so that there's more administration sites so that it doesn't have to be so targeted as to where you would go get your vaccine. But here in this initial phase rollout, it has to be very focused so that there's proper allocation of those doses in those individual areas. I know that that leads to some confusions because individuals get an email. When you register in VAMS, it's based upon a radius. It's defaulted at a 10-mile radius. I recommend expanding that search out, and then you can find another pharmacy, and then you make your appointment time and go and receive your vaccine. So we're going to be sharing some additional information through the various boards that will hopefully help make that process easier as we continue to receive many calls and inquiries about that, and certainly want to make sure that everyone, that provide critical services. The principles guiding these decisions are, to protect our most vulnerable, reduce hospitalizations, reduce deaths, and then maintain critical services, including our acute care system. And those guiding principles are really what the pandemic leadership are using to make the decision in regards to subsequent doses of vaccines that are allocated to various populations. And as the supply increases, we'll be able to open up more to the general population. So I know that that's a lot. I know personally, I don't probably read my emails as thoroughly as I should. We all probably have gotten really good. Perhaps it's my inner pediatrician that we just scroll too much, but it is really important to follow the instructions that are sent to try to reduce any hiccups that individuals may see. Individuals can always reach out to me, and I'll be happy to help however I can. But that is how we have kind of taken the approach to try to reach individuals as we do this rollout of this vaccine program. But it is very flexible and dynamic and changes based upon how much we get from the federal government. There's a lot of other moving parts. Not only do you have to get the vaccine, you have to get the ancillary kits, so the syringes, the alcohol, the other components that go with administering the vaccine. So we are continuing to do our best to meet everyone's needs. And that's a brief kind of overview off the top of my head, and I'd be happy to address any questions. I think maybe some came through the chat.
Thank you so much, Dr. Costello, and we'll be sure to check our junk emails and spam and everything. It's always important to do. I know Dr. Davison also chatted in something I wanted to share with the group. She said she can't take credit for this description, but she heard this and she thinks it's a great way to look at the vaccine distribution. So it goes, it is not a single file line, there are many lines. And she says she thinks looking at it this way can alleviate some of that anxiety over fairness. So thank you so much for sharing.
Dr. Davison, thank you so much. I've been trying to come up with a way, and I do think that that's a way to kind of depict it. So I will also not take credit for that, but that may show up in some other messaging events. But yeah, I think that that is a good description. There's kind of multiple lines to try to get multiple people through the line, if you will. So yeah, thank you for that description.
Thank you. And I did want to leave some time for the poll as well here at the last